Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCrae.
You know, you may wonder what allergies and asthma have in common besides making you miserable. Well, a lot, it turns out. Allergies and asthma often occur together.
I thought you were just going to say they both start with the letter A.
Well,
but there's more to it?
Good point also.
Okay.
Yep. The same substances that trigger your hay fever symptoms like pollen, dust mites, and pet dander can also cause asthma signs and symptoms. And in some people, skin or food allergies can also cause asthma symptoms.
When it comes to children, asthma can be especially problematic. Asthma is one of the leading causes of emergency department visits, hospitalizations, and missed school days. Here to discuss is Dr. Martha Hartz, the Division Chair of Pediatric Allergy and Immunology in the Mayo Clinic Children's Center. Welcome back to the program, Dr. Hartz. It's been too long.
I know, it's been a while. Yeah, a few years.
Dr. Hartz, good to have you. So explain to all of us when we talk about asthma, what are we really talking about? What's the problem?
The best way to discuss asthma is to say it's recurrent bronchospasm. So it's inflammation inside the airways that cause or trigger bronchospasm, increase mucus production, some need for a bronchodilator. And if it happens one or two times, we say, well, you had some bronchitis perhaps, or viral-induced bronchospasm. But if it happens recurrently, then it has an increased likelihood of happening again. And then at a certain point, we call it asthma. Now, most people say that asthma is probably a variety of diseases that we're lumping under one category to call asthma. But for the sake of parents and patients, what it feels like is I have these recurrent, quote, asthmatic bronchitis episodes that continue to recur. So,
It make it difficult to breathe.
yes. So patients feel like they have a difficult time getting air out. They feel sometimes kids will describe it as feeling like they're breathing through a straw. Kids will also talk about chest pain. Older children and adults usually are able to characterize it a little more subtly than pain. They'll say chest tightness. And usually patients can identify a trigger. So usually in children, the trigger most often is a viral infection. Secondly would be exercise, and in adults, and thirdly would be allergic triggers, so aeroallergens, breathing in things that trigger the response. Yeah.
Do we know why some people get asthma and who's at risk?
The patients that are at risk are patients that have a family history of any of the atopic diseases. And the atopic diseases include asthma, atopic dermatitis, allergic rhinitis, food allergies.
Rhinitis, inflammation of the nose.
Yes, stuffiness, postnasal drip, drainage from the nose. So, and then some other less common conditions like eosinophilic esophagitis, which is almost like a asthma of the esophagus. So those are the people that are at risk. Are if you have one of those conditions or more than one of those conditions, then you're more likely to have the others. So if you have food allergy, you're more likely to have asthma. If you have atopic dermatitis or eczema, you're more likely to later develop asthma. And then what is going on in the airways basically is swelling of the lining of the airways and increased mucus production. And then that leads to bronchospasm. And that's what people take their inhalers for asthma, is they take it for one, preventative medication reduces the inflammation and twitchiness of the airways. And then the medications most patients are familiar with is like albuterol, for example, that helps open up the airways and relieve bronchospasm.
It seems that there's a lot more asthma now than in previous generations. Am I just becoming more aware of it, or is that the case?
Yes, it is the case. So it's actually stabilized recently, but over time in westernized countries, asthma is increasing in prevalence, as is food allergies, as is atopic dermatitis, as is allergic rhinitis, and eosinophilic esophagitis, or EOE. So all of these things are becoming more common, and in particular in westernized countries.
Why? And you can't say, I don't know, or we don't know.
So patients always ask this question. And so we have some theories. So, for example, if you go, patients themselves who immigrate from another country that's a developing country will remark on how their own children have these atopic diseases, but their extended family back in their country they came from do not have these. So there's lots of theories that developed after this epidemiology, or this this difference between populations was identified. And one of them is called, it's a hypothesis that's been around for about 20 years, is the hygiene hypothesis. So our very hygienic world sends your immune system, the T cells part of your immune system, down the allergy pathway instead of either down the pathway that arm of the immune system was meant to do, which is fight worms and weird things. Most of the world's population, like a third of it, has, I guess that's not most, but have parasites. But you go to a westernized country and that's not the case. The other thing is, if early on in life you're exposed to endotoxin, toxin in stool makes you less likely to develop allergies. If you're exposed to infectious illness. So there's some things that follow this same pattern in the United States. So, for example, if you are born to a farm family where no matter how clean your house is, there's some animal products that you can measure that's increased. Those kids have less asthma, food allergies. And so if you have a dog, and most of us who know dogs, they're not the neatest. So if your child is born to a household with dogs, you're less likely to develop these allergic conditions.
So our hygiene in this country is too good. A little dirt or whatever is
bugs.
okay. Yeah.
Dirt is okay.
Yeah.
In fact, I have a colleague who tells her daughter to have her grandson lick the floor of O'Hare Airport to help prevent allergies.
Lick the light switches wherever you go.
Yes. So there are upsides to our hygiene. There's not as much illness at birth. There isn't as often do you have tuberculosis or a lot of these hepatitis C. A lot of illnesses are lowered, infectious illness in westernized countries, but typically that's not a lot we can control. Perhaps at some point we might be able to give babies things like endotoxin to help prevent these things.
So the hygiene thing can be overdone.
Yes, it can,
All
from
right,
an allergist standpoint.
Right. We're talking allergies and asthma with the Division Chair of Pediatric Allergy and Immunology at the Mayo Clinic Children's Center, Dr. Martha Hartz. Time for a short break.
When we come back, myth or matter of fact, children can outgrow their asthma. We'll find out.
Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCrae.
We are with the Division Chair of Pediatric Allergy and Immunology at the Mayo Clinic Children's Center in Rochester, Dr. Martha Hartz. So let's go with the myth or matter of fact.
Myth or matter of fact, Dr. Hartz, children can outgrow their asthma. Myth or fact?
We don't tend to say the word outgrow, but it can become asymptomatic. So most people who develop asthma as an adult will have a history of having had it as a child. So if patients get markedly better, we can take them off a medication. But I always caution them that someday in the future, if they find themselves having these symptoms again, then that means the asthma has reared its head again. It's not necessary. We don't use the word outgrow forever kind of thing.
So let me just summarize then about asthma. You said that it's a condition in which there is spasm and inflammation of the airways. The number one risk factor is for having a family history of asthma or other diseases that you mentioned. And most patients can be treated with inhalers successfully.
Yes. So there are two types of medications we use for asthma. One we call the rescue medication or the symptom reliever, and that's the albuterol is typically the one that's used. And we have people use that if they experience symptoms of cough, wheeze, or shortness of breath. And then for prevention, we use typically an inhaled corticosteroid.
Like prednisone.
An inhaled corticosteroid would be something like fluticasone that you...
Anti-inflammatory.
Yeah,
Strong
it's
anti-inflammatory.
a steroid that is not like the bodybuilding steroids. It's an anti-inflammatory steroid that you breathe in through an inhaler. And that's the hardest concept for patients when they feel better, is that we want them to keep taking the medicine because it makes your airways less twitchy if you get one of your triggers, like a viral URI. So that preventative medicine is that inhaled corticosteroid, like hydrocortisone type of stuff. And then there's sometimes we use what's called a long-acting bronchodilator in combination with the steroid as a preventative. So,
all right. So basically the treatment is inhalers of one kind or another, either for prevention or an acute attack.
Yes. Now, sometimes you get a bad enough attack, as you mentioned, that we need some oral prednisone, and that will give for a short course if people get a really bad flare and their inhaler, their albuterol rescue inhaler, isn't keeping them asymptomatic very long in between uses.
How do allergies and asthma go hand in hand? Why are they mixed?
Okay, so what I like to tell patients is that allergies can be a trigger for all of these conditions. So you can have allergies as a trigger for asthma, but it doesn't have to be. Allergies for a trigger of your nose symptoms, but you can have non-allergic nose symptoms. Allergies can trigger your eczema, but they don't have to.
And that's a skin problem, eczema.
Eczema is, it's a skin problem. So it's more like the allergies can be a trigger for the asthma. So patients will notice, for example, that they get around their cat and they start to cough or wheeze. It could also trigger nose symptoms or nasal symptoms as well. So,
what about peanuts? We hear once in a while about a child who has a severe peanut allergy that maybe they didn't know about, and it actually can result in death. Should you expose your child to peanuts at a young age?
Okay, yeah, that's a really good question. It's so current recommendations just within the last couple of years are that if patients are at high risk of a peanut allergy, then they should be exposed early, and that'll help prevent peanut allergy. So. So there's been some good research to support this. And so patients with significant eczema, the skin rash early in life, or another food allergy like egg allergy, those patients should be assessed by their doctor And we might have the parents introduce peanut in a very specific way as early as 4 to 6 months of age.
So if you find out that you have a peanut allergy, some of these kids and probably even adults carry an EpiPen. Tell us how that works.
Okay, so one of the really important parts of having any type of food allergy is, aside from ending up having to avoid taking the food, and we give a lot of instruction in terms of how to read labels. We also prescribe an auto-injector of epinephrine, and that's in case you did accidentally get the food allergy. So patients always ingest the allergenic food when they least expect it. So our expectation is that they carry epinephrine in case of accidental ingestion, and it's life-saving. So.
You mentioned that before when we were talking about asthma, you need to know the different things that trigger the asthma.
Right.
When it comes to allergies, can different types of allergies trigger asthma? I mean, you mentioned that part, but like food allergies, can that trigger asthma?
Generally, for a trigger for asthma, we're looking at aeroallergens, so things in the air, pollen, animal dander, house dust mite. For food allergies, the only way, it's not like a mystery food that could be doing it. It's not like a hidden milk allergy is causing you triggering your asthma. It would be more like if you have an acute, like an ingestion of peanut, for example, and you have asthma, then that in the context of that bad allergic reaction, it can trigger bronchospasm. So patients with asthma and food allergy have a higher risk of a severe reaction when they do have an accidental ingestion.
And the severe reaction is that the breathing tube squeezed down so hard that the patient suffocates.
Right.
Is that
So
how they die?
yeah. And so patients, we do let the schools know that patients that have asthma are at higher risk of a severe reaction to the food.
Well, obviously don't want that to happen.
No.
So have an EpiPen with you.
Yes,
Certainly if you
always have
a
your
severe
EpiPen.
allergy. Yep.
We have about 20 seconds left. What does the future for children for pediatric allergy and asthma, what does that hold?
The thing I'm most excited about is the immunotherapy that's being developed for food allergy. And one is an epicutaneous patch, very similar to a nicotine patch, and it's going to be approved first for peanut, and then slowly increase the amount of peanut through the patch and avoid a lot of the problems with desensitization now.
So that would be for somebody that you know has a peanut allergy, or somebody who is is at risk for getting one.
It would be a treatment.
Oh,
so,
okay.
yes.
So then you wouldn't have to carry the EpiPen maybe if this
yeah,
works.
I'm not
You
sure
still
all
have
the
one.
specifics, but a small ingestion should not trigger a big reaction. Is the
We
bottom
hope.
line.
All right. We hope that work is successful.
Yes.
Thanks so much for being with us, Dr. Martha Hartz, Division Chair, Pediatric Allergy and Immunology at the Mayo Clinic Children's Center. Thank you.
You're welcome.